Hello, this is Mrs. Mattingly again, and this particular collaborate is another of your pre-lecture collaborates for the acute neurology lecture. And this one we're going to talk about intracranial pressure and increased intracranial pressure and caring for that client. Okay? So the first couple of slides, like always, are going to be your outcomes and your cues, and so I'm just going to flip through those and not talk. So okay, just hold on a minute. Okay, here we are at the first one. So in the first collaborate that you listened to, we reviewed the nervous system. So we're going to kind of touch a little bit on the nervous system and the brain again. So the brain itself is composed of three essential elements. You've got the skull. Okay, then inside that skull you've got the three essential elements, which are the brain tissue, the blood, and the cerebral spinal fluid. And for the most part, under normal processes, that intracranial pressure remains fairly constant because those three elements create a balance. And that's what's called the Monroe-Kelly doctrine, and that says that if one component increases, then another must decrease in order to maintain a normal intracranial pressure. The Monroe-Kelly doctrine only works in situations where the skull is closed. It's not valid in individuals with a displaced skull fracture or a hemicraniotomy. So you've got the intracellular and the extracellular fluids of the brain tissue, and combined, those two make up about 78% of the volume. You've got the blood and the arterial, venous, and capillary network that makes about 12% of the volume, and then the remaining 10% is the volume that comes to us through the cerebral spinal fluid. What all that intracranial pressure is it's the hydrostatic force measured in the brain CSF compartment. That's all it is, okay, to start out with. Then, moving on, this slide kind of reinforces that general statement that I said. Now, ICP can be measured in the ventricle, the subarachnoid space, the subdural space, the epidural space, or brain tissue using a pressure transducer. The normal range for intracranial pressure is 5 to 15, okay? Then you've got on your slide mildly elevated, moderately, and severely elevated. But for purposes of thinking about increased intracranial pressure, what I want you to remember is that a sustained pressure greater than 20 millimeters is considered to be abnormal and must be treated. Okay, I'm going to repeat that. So for purposes of thinking about increased intracranial pressure, if you've got a reading of 20 millimeters or higher for a sustained period of time, that's considered to be abnormal. In other words, that's considered that the patient has increased intracranial pressure and it has to be treated. Okay? Some factors that influence intracranial pressure are right here on your slide. I'm not going to read them to you because they're here on your slide. Okay? The degree to which these factors increase or decrease the intracranial pressure depends on the brain's ability to adapt to changes. So the more flexible the brain is, we're going to do a better job of managing that intracranial pressure. Moving on to the next slide. We've got regulation and maintenance. And this, again, goes to that Monroe-Kelly doctrine that we talked about, that for the most part, the body can adapt to volume changes in one of three different ways. First, we can have compensatory mechanisms that include changes in the cerebral spinal fluid itself. That volume can be changed by altering the CSF's absorption or production, and also by displacing the CSF into the spinal subarachnoid space. Another way that we can compensate is we can make changes in the intracranial blood volume, and that can happen through the collapse of cerebral veins in the dural sinuses. We can have regional cerebral vasoconstriction or vasodilation, depending on what we need to do. And a third way is that the brain volume compensates through the distension of the dura or the compression of brain tissue. Initially, an increase in volume produces no increase in intracranial pressure, because of this compensatory mechanisms that we've kicked in on, okay? But then what happens is that we have a limited amount. Remember, that skull is like a closed box. So we have a limited amount of leeway, I guess would be a good word to use, on how we can compensate. So as the volume continues to increase, then we will start to see a rise in the intracranial pressure. And then ultimately that decompensation just occurs, and we end up with compression of the brain tissue and ischemia. The cerebral blood flow is the next slide, and I'm going to flip to that. So as far as cerebral blood flow, this is the amount of blood that passes through 100 grams of brain tissue in a minute. Another way to think about that is 50 milliliters per minute is another way to think about that. It's important that we maintain the blood flow to the brain because the brain requires a constant supply of both oxygen and glucose. The brain uses about 20% of the body's oxygen and about 25% of its glucose. So we've got to constantly be feeding that brain tissue. It has the ability to regulate its own blood flow in response to its metabolic needs, even when there's wide fluctuations in systemic arterial pressure. This is an automatic autoregulation adjustment that results in changes in the diameter of the cerebral blood vessels. And the brain does this to maintain a constant blood flow. The purposes of autoregulation is to ensure that we have a consistent cerebral blood flow to provide for the metabolic needs of the brain and to maintain the cerebral perfusion with oxygenation. Lower limits of the systemic arterial pressure in which autoregulation is effective in a normal intensive person is if we have a MAP. Remember MAP from back in shock. We have to have a MAP of at least 70, okay? If we fall below that, then we're going to see a decrease in the cerebral blood flow, and we're going to have symptoms of cerebral ischemia. And that might show up as syncope, blurred vision, those types of things. Just like there's a bottom or a lower amount, there's also an upper amount. So the upper limit of systemic arterial pressure in which we can still have any of that autoregulation going on is a MAP of 150. When we get above that, the vessels are they're as constricted as they can get, okay? And any further response of vasoconstriction is just totally lost. And the next slide is going to remind you about MAP, and particularly as it relates to cerebral perfusion. So here we're going to go to the next slide. Okay, this slide reminds you a little bit about MAP, and it talks about cerebral perfusion. You can see the text, you can see in the text, you can see table 57-1 to see how you calculate cerebral perfusion pressure. If the cerebral, let me back up. The cerebral perfusion pressure is needed to make sure that we've got adequate blood flow to the brain. When you go to look at how you get cerebral perfusion pressure, what it is it's equal to the MAP, thinking back to shock, it's equal to the MAP minus the ICP, okay? A normal CPP is between 60 and 100. As it goes down, we'll see autoregulation fail, and then we'll see CVF decrease. If we've got a cerebral perfusion pressure of less than 50, then we're going to have ischemia, and we're going to have neuronal death, okay? If when we get down less than 30, we're going to see that we've got profound ischemia, and that is just incompatible with life. Normally, our autoregulation maintains an adequate cerebral blood flow, and so then we have adequate perfusion, okay? So we can go back all the way to shock and think about MAP, and so we can see that maintaining MAP is crucial whenever we want to talk about managing cerebral blood flow, okay? We want to pay attention to it when we see we have an increased intracranial pressure. MAP is also something that we need to be watching for. Okay? Then the slide also tells you the effect of cerebral vascular resistance, okay? We're going to move on to the next slide. I'm just going to remind you about MAP. Here we again show how we calculate MAPs, this, in case you can't remember back to when we talked about this in shock. So that's back from the sepsis and mods, okay? And this goes back to, I think, something that I said back then, that vital signs is more than just taking vital signs. We always need to interpret vital signs. Remember, the body's going to try to regulate. Remember, we have an upper and a lower. So MAP has to be, we want MAP to be at least 70, and we want it to not be more than 150 for the cerebral blood flow to be effective. If MAP drops to 50 or less, we just simply cannot perfuse the brain. Okay? A couple of factors influence cerebral blood flow, including carbon dioxide, oxygen, and the hydrogen ion. If we see an increase in the partial pressure of carbon dioxide in the arterial blood, that's going to relax the smooth muscles, so it's going to dilate the cerebral vessels. That's going to decrease cerebral resistance, and it's going to increase cerebral blood flow. Okay? By contrast, then, if you just think about it, if you see a decrease in the carbon dioxide in the arterial blood, then you're going to see a constriction in the cerebral vessels, which is going to increase cerebral vascular resistance and decrease cerebral blood flow. So that makes sense, okay? As far as oxygen, the cerebral O2 tension of less than 50 millimeters is going to give us cerebral dilation, cerebral vascular dilation. This dilation is going to decrease the cerebral vascular resistance, which is going to increase cerebral blood flow. Okay? If we don't increase oxygen, then we're going to fall into the anaerobic metabolism. We don't want to fall into the anaerobic metabolism because if you go back again, when we talked about this in shock, if we've got anaerobic metabolism, we're going to start to produce lactic acid. Okay? As the lactic acid increases, then we're also going to see an increase in the hydrogen ions. And the environment now that the brain is in becomes acidic. With once the brain becomes acidic, we're going to have even further vasodilation because we're continuing to try to increase that blood flow. A combination of a very low partial pressure of oxygen in the arterial blood and an elevated hydrogen ion concentration is going to result in acidosis. And this is going to produce a state where autoregulation is just lost and the compensatory mechanisms just fail. And we just can't meet our metabolic tissue needs at that point. Okay? We're going to move on. This kind of goes through and tells you again on this slide what I just told you a little bit. Remember that as the intracranial pressure increases, the brain's going to work to maintain that blood flow. Okay? We want to keep some steady perfusion. We can do that if we're keeping that systolic pressure between 50 and 150 millimeters, and if the ICP is less than 40 millimeters. When we think about autoregulation, we think about the brain's ability to change the diameter of the blood vessels to maintain perfusion, and blood pressure is what's going to regulate that. The lower limit of MAP, remember we talked about that, is 50, and below that we're going to have a cerebral ischemia, and the upper limit is 150, and beyond that, we've done all the vasoconstriction that we can do. We are totally maxed out. We need to have adequate CPP to ensure blood flow to the brain. Remember that as CPP decreases, autoregulation begins to fail. A normal CPP is 60 to 100. And when we talk about compliance, that talks about the expandability of the brain. When autoregulation fails, we're going to see an increase in intracranial pressure. the blood pressure is going to try to respond by increasing, so the blood pressure is trying to help us keep the brain perfused. So just like we had stages of shock, we've got stages of increased intracranial pressure, and that's on the next slide. So we've got stages, like I said, just like we had in shock. In stage 1, the brain is in total compensation. It's accommodated, it may have increased or dilated blood vessels, but the brain is doing its thing and it's kept us in compensation. That is great, okay? Then we move into stage 2. Stage 2, the compliance is beginning to decrease. We start to see an increase in volume, and this places the patient at risk for increased intracranial pressure and secondary injury. So the compensation is beginning to fail, and we start to see an increased risk for increased intracranial pressure. At stage 3, the compensatory mechanisms have failed. They're failing, they're going down the drain, okay? So they're failing. There's a loss of autoregulation, and the patient now is going to fully exhibit manifestations of increased intracranial pressure. So you might see changes here like headache, changes in level of consciousness, or changes in pupillary response. With the loss of the autoregulation, there's still an attempt to maintain that cerebral perfusion like I talked about a couple slides ago, and so what the body's going to try to do is increase systolic blood pressure. However, we're just too far along for that, and decompensation is imminent. The patient's response is characterized by systolic hypertension with a widening pulse pressure. You've got bradycardia with a full and bounding pulse, and you've got altered respiration. This put together is what is called Cushing's triad. Okay, so I'm going to back up again. We've got decompensation is just right around the corner. The body's trying to respond, and the way that it tries to respond is by increasing systolic blood pressure. So what you've got is you've got systolic hypertension, you've got a widening pulse pressure, you've got bradycardia, but even though you have bradycardia, you've got that full bounding pulse, and you have alterations in the respiratory status, and that's what's on that slide here. Now, Cushing's triad is a neurological emergency, okay? What's going to happen is you're going to see irregular breathing. As the intracranial pressure continues to increase, that heart rate's going to increase, the breathing's going to become more shallow, you're going to have periods of apnea, and the blood pressure then will start to fall. Eventually, you're going to go into an agonal rhythm, and that's going to develop as the brain starts to herniate. Remember, we talked about herniation is whenever that brain tissue extends down through the foramen magnum. And then soon after that, you're going to see the cessation of brainstem activity, which is then in turn going to result in respiratory and cardiac arrest. Okay. So we're going to move on over, still talking about increased intracranial pressure. Intracranial pressure is considered to be a potentially life-threatening situation. It results from an increase in any of those three components that we already talked about, and those three components are listed on your slide there. An elevated intracranial pressure is significant because it diminishes the cerebral perfusion pressure. So when we do that, we've got risk of the brain becoming ischemic. We can also have infarction, and this is associated with a very poor prognosis for the client. We can have several causes of increased intracranial pressure, and it can be from any of three components. So common causes include a mass, so that would be something like a hematoma, a contusion, an abscess, those types of things, a tumor. We could have cerebral edema. This could be associated also with brain tumors, hydrocephalus, or a head injury, or brain inflammation, okay? These cerebral insults can result in hypercapnia, which is increased carbon dioxide in the blood. We can end up with cerebral acidosis, The autoregulation is impaired. We've got the systemic hypertension going on. And we've got more and more cerebral edema developing. That brain is just continuing to develop edema. It's very important that we have adequate cerebral blood flow in order to preserve the tissue and minimize secondary injury. If we've got a sustained increase in intracranial pressure, we're going to have brainstem compression, and typically then we're going to have herniation of the brain from one compartment to another. Whenever we've got displacement and herniation of the brain, this causes a potentially, at this point you still have some reversibility, but it's going to very quickly become irreversible. You've got ischemia and edema. You've just got further increases in both of these areas that just continue to compound the problem. When we talk about cerebral edema, it's defined as an increase of accumulation of fluid in the extravascular spaces of the brain. There's a variety of causes. Remember, we talked about we could have lesions, head injuries, infection, cerebral infection. We could have a vascular insult, or we could have some type of a metabolic issue, or we could have toxic issues. But regardless of what the reason is, okay, the cerebral edema results in an increase in tissue volume, and when we have that increase in tissue volume, remember that skull is a closed cavity, so we're going to see an increase in intracranial pressure. The the degree, and the severity of the original insult are factors that impact the response in how much cerebral edema we have. Okay, there's 3 types of cerebral edema. They're listed there, and we're going to talk about each one on the following slides. Okay. So the first one we're going to talk about is vasogenic cerebral edema. It's the most common kind of cerebral edema. It occurs mainly in the white matter, and it's characterized by a leakage of the macromolecules from the capillaries into the surrounding extracellular spaces. You can have a variety of things that impact this. It could be something like a brain tumor, abscess, toxins. Any of these things can cause an increase in the permeability of the blood-brain barrier and produce an increase in the extracellular fluid volume. How fast it spreads and the extent it spreads the edema is influenced by the systemic blood pressure, the site of the brain injury, and the extent of the blood-brain barrier defect. It gives you a continuum of symptoms which are listed there on the slide for you. So something to think about in this particular slide is headache. Okay, headache doesn't always seem to be all that significant when we hear about it, but a headache could be an early symptom of cerebral edema. And in this particular situation, it can quickly progress to coma or death. So it's important, again, not only to think about symptoms or take vital signs, but again, we've got to think about them in context of the situation. So we need to always be vigilant in our assessment skills as it relates to the situation. Moving on cerebral edema. The other 2 types are cytotoxic and interstitial. When we talk about cytotoxic, it results from a disruption of the integrity of the cell membrane. This could come from destructive lesions or trauma to the brain tissue. This can also be from SIADH secretion. In this type of edema, we have the blood-brain barrier remaining intact, with the cerebral edema occurring because of fluid and protein shift from the extracellular space directly into the cells. And then as a result, we have swelling and we have loss of cellular function. Interstitial cerebral edema is usually a result of hydrocephalus. And hydrocephalus is just the buildup of fluid in the brain, and it's manifested by ventricular enlargement. This could be because we have too much CFS being produced. It could be because there's an obstruction in the flow of the CFS, or an inability to absorb the CFS. And if you need to remember about CFS, you know back where I talked about ventricles, okay? Hydrocephalus, we usually treat that with ventriculostomy or ventriculoperitoneal shunt. So there's a couple of ways we can treat that. This increased intracranial pressure, again, this is kind of a slide that's rehashing stuff that I told you several slides ago just to help you to remember it. Remember that we've got auto-regulation of the brain. We're going to have that initial compensatory mechanisms, and we're going to go through those stages that we talked about. In the early stages, we're going to see the systemic pressure rise in order to maintain that cerebral blood flow. Remember, you're going to have that slow bounding pulse and respiratory irregularities. We want some things that we can do is we can hyperventilate in order to help with the perfusion. Because remember, if we don't keep that oxygen tension high enough, we're going to have anaerobic metabolism, which is going to result in the production of lactic acid. So this slide kind of just reinforces the slide that I think was 4 slides ago. Oops. Okay. I've been talking about herniation, so I've got a couple of pictures up here. And this picture actually is straight out of your book, so you can look in your book for this picture also. So anyhow, brainstem herniation results when there's an excessive increase in intracranial pressure. As the pressure builds up, you've got the skull, you've got the cranial vault and the brain tissue. And it's, like I said, the skull is only just, it's a rigid, it's a closed box. So you've got more and more swelling. You've got that brain tissue pushing out there, and there's nowhere to go. There's just this one opening, okay? And so what happens is it presses down on the brainstem, and we end up with a cessation of blood flow to the brain and death. We can have a couple of different kinds of herniation. We can have a tentorial herniation, which is a central herniation. It occurs whenever you've got a mass lesion in the cerebrum that forces the brain to herniate downward through the opening created by the brainstem. You can have an uncal, U-N-C-A-L, an uncal herniation is when you've got both a lateral and downward herniation. Or you can have a cingulate, C-I-N-G-U-L-A-T-E herniation, and that's when you've got a lateral displacement of the brain tissue beneath the falx cerebri, F-A-L-X-C-E-R-E-B-R-I, okay? When you look at the pictures there, you can see an A, that's showing you the normal relationships of intracranial structures. Then B shows you the shift of intracranial structures. You can see compression in the brainstem and the cranial nerves can be fatal. And then it talks about how that herniation forces the cerebellum and the brainstem downward through that foramen magnum. Remember, I talked about that way back, I think all the way back when the nervous system collaborate. That's really the only big opening in the cranial vault. So, I mean, that's the only place the brain has to go. If the compression of the brainstem is on relief, we're going to have respiratory arrest, and that happens because we have compression of that respiratory control area that's located in the medulla. Recognizing signs of ICP is the next slide. Let's go to that. So when we talk about recognizing signs of ICP, I'm going to say something you've heard before. The earliest and most sensitive sign of increased intracranial pressure is changes in level of consciousness. You've heard that before, haven't you? The reason that we see changes in level of consciousness is because it's a result of impaired cerebral blood flow, which deprives the cells of oxygen. As the patient becomes stuporous and unresponsive only to painful stimuli, the brain circulation is very, very impaired. Be aware that changes can be quick, okay? So some of the things that you might see is you might see a slowing of speech and response, and then you might see restlessness, confusion. This can progress very quickly onto disorientation, on into lethargy. There should be a comma between disorientation and lethargy, and then we can move all the way into coma. The earliest sign that you might see is simply a flattened affect. We talked a little bit ago about Cushing's triad. Remember Cushing's triad. Cushing's triad is a neurological emergency. Whenever we see Cushing's triad, it's usually not an early sign. And when we see Cushing's triad, usually we've had increased intracranial pressure for some time. Or it can also pop up if we see a really sudden marked increase in intracranial pressure. So it can come up either way. We can also have some ocular signs. The ocular signs that we would see is we would have compression of cranial nerve 3. Remember back I told you you're going to need to know a little bit about these cranial nerves because we're going to talk about them as it's related to pathology. So this is cranial nerve 3, the oculomotor nerve. And what's going to happen then is you're going to see a dilation of the pupil on the same side as the mass or lesion. When we have something on the same side, we're going to call it ipsilateral, I-P-S-I-L-A-T-E-R-A-L. And what you're going to see is you're going to see no response to light, or you're going to see a very sluggish response to light. You can see an inability to move the eye upward, and you're going to see ptosis, or drooping of the eyelid. Okay? We're still recognizing signs of increased intracranial pressure. Oh, I meant to take that first part off. I see that there. That first part. So you just get a rehash of changes in level of consciousness. But let's jump down to change in vital signs. The change in vital signs, again, I've listed Cushing's triad here for you. So again, I'm just telling you again what Cushing's triad is. The other thing I want to say underneath the vital signs is that you can also see a change in body temperature. And this is because the increased intracranial pressure impacts the hypothalamus. So what we want to do is we want to try to keep that temperature between 96.8 and 98.6. That's pretty easy to remember because you just have to remember to transpose the last two numbers, okay? 96.8 to 98.6. It's a pretty easy range to remember. The reason we want to keep this here is we want to avoid any kind of body reaction such as shivering, because if we start shivering, we're actually going to further increase the intracranial pressure. I do want to talk just a little bit about changes in consciousness. We can see just that minor change, or we can see a very dramatic change. In the deepest state, or coma, that's whenever that patient's not going to even respond to painful stimuli. At that time, you're also going to have an absence of both corneal and pupillary reflexes. Remember, at this point, that patient can't swallow, they can't cough, they're incontinent. If we do an EEG on them, that pattern's either going to be very suppressed or it's going to be absent of any type of neuronal activity. I guess that's all I really want to say on that slide. Okay. Compression of the oculomotor nerve. I talked about it earlier, but here I have it nicely written out for you on the slide. Okay. We talked about herniation. I talked about those a little bit ago, but I've also given you some more information in relationship to how the pupils react in herniation. Some other cranial nerves. Let's see. We can have cranial nerves 2, which is the optic nerve, 4, which is the trochlear, and 6, which is the abducens. Those can all be impacted as well. And what we would see with that kind of an impact is blurred vision, diplopia, and changes in the extraocular eye movement. Let's see, what else do I want to tell you? Oh, I know what I want to tell you. Because of that depression of the cranial nerve 3, that can result in the paralyzing the muscles controlling the pupillary size and shape. So in this type of situation, if you have a fixed, unilateral, dilated pupil, that's considered to be a neurological emergency, because if you have a fixed, unilateral, dilated pupil, that's an indication that the brain has herniated. Moving on. This slide just shows you pictures of pupillary response. I'm not going to talk about it. The next slide is going to talk about posturing. Okay, this picture is actually in your book, okay? Something that you do want to be knowledgeable of and recognize that as the intracranial pressure increases, we see manifestations to changes in our motor ability. Something that we can have start to happen is something that's called posturing. This is a direct result of a decrease in our motor function. So the first one on there, A, that is a decorticate response. Okay, so whenever we talk about decorticate, that's where you've got an internal rotation and adduction with a D, adduction of the arms with flexion of the elbows, wrists, and fingers. And this results because of an interruption to the voluntary motor tracts in the cerebral cortex. You can also see extension of the legs. Okay, the way that I remember this is decorticate, and I think about everything turning internally towards the core of our body. So we're just turning everything we can towards the core of our body. That's how I personally can remember it, okay? Then if you go to B on there, we can go to decerebrate, okay? Now, decerebrate posturing is the sign of worsening of the condition. So it means more serious damage. It also results from the disruption of motor fibers. We've got motor fiber disruption in the midbrain and the brainstem. In this position, it's the opposite, is the way that I think about it. The arms are stiffly extended, or it's still adducted, but now we're hyperpronated. So if you look at B, you can see how his arms are still close to his body, but see how they're kind of turned outward, away from the body, and that's how I can remember the difference between decerebrate and decorticate, to be quite honest, so I can remember that. Another way to think about it is this is very extended. Think about this as you're totally extended. So if you go past the arms and you look down there at the feet and the legs, what you've got then is you've got extension of the legs, you've got an internal rotation, and you've got plantar flexion. Excuse me, I said that backwards. Wrap that around here. You've got rigid extension, you've got hyperextension of the legs, and you've got plantar flexion of the feet. Okay? All four extremities are in very rigid extension. You've got hyperpronation of the forearms. Now that middle one, C, it shows you mixed posturing. You can see that you've got a decorticate response on the right side. See how that right arm is flexed up, everything coming to the core of the body. Then on the left side, you've got a decerebrate response. See how that's different? That last one is hard to see, okay? But that last one was what's called opistonic posturing, O-P-I-S-T-H-O-T-O-N-I-C. E-P-I-S-T-H-O-T-O-N-I-C. This is where you've got severe hyperextension and spasticity. And the way that I think of it is that's where you can see that bridging or that arching position of the spine. This is an abnormal posturing. It's the result of an extrapyramidal effect, and it's caused by a spasm of the axial muscles along the spinal column. A place that you would see this type of posturing would be with traumatic brain injury. Okay, but this is, you can kind of think of it as almost them arching up off of the bed. Okay, recognizing signs of ICP. I'm just really beating that in, aren't I? Remember headache. So often The headache is continuous, and a lot of times it's worse in the morning. Remember that the brain itself is insensitive to pain, but it's the compression of other intracranial structures like the arteries and the veins and the cranial nerves that actually produces the headache. Also, if you go back again to the nervous system lecture, remember we have a vomiting center in the brain. So as we get increased intracranial pressure, we can trigger that vomiting center. Vomiting with increased intracranial pressure is a little different than normal vomiting. Usually there's no sense of nausea, so it can be so it's called unexpected because you're not nauseated, you're not expecting to throw up, but you have this sudden vomiting. You can also see projectile vomiting as well. The next slide kind of gives you early signs and late signs. I'm not going to talk about the slide other than tell you one thing. Your book is going to tell you that pupillary change is early, but it really truly is a later sign. Remember that vomiting might be projectile or it might be without nausea. That's why it's called unexpected. This is another slide just showing you again the symptoms of increased intracranial pressure in a different way. If you're a visual learner, this might be the slide for you. Complications of increased intracranial pressure include brainstem herniation, and that's the result of an excessive increase in intracranial pressure. We can also see diabetes insipidus. Remember, this is too much P, and it results from a decrease in the production of ADH when that body's trying to compensate for increased ICP. So we've got too much urine output, we've got decreased urine osmolality, and we've got serum hyperosmolality. We treat this with fluids, electrolytes, and medication. Or we can have the flip side. We can have SIADH, when in this case we don't have an FP. So now we've got too much secretion of ADH. The patient now becomes volume overloaded. They've got fluid retention, there's decreased urine output, and the serum sodium concentration is diluted. Let's see. We treat this with fluid restriction, and in severe cases we can use a hypertonic saline solution. Sometimes we give lithium. We want to monitor electrolytes and output, and of course another huge complication of increased ICP can be death, not one that we really want to encounter. From a Diagnostic Studies perspective, you can look at Table 57-3. This includes both diagnostics and collaborative therapy. We can use various diagnostic studies to identify the cause of increased intracranial pressure. We can use CT and MRIs, which is really, when we were able to start doing this, we really were able to make huge progression as far as diagnosing increased ICP. We can use this to differentiate between the different conditions. We can also use PET scans. We can use things like an EEG or cerebral angiography. We can measure ICP. We'll talk a little bit more about that. We also can measure brain tissue oxygenation with the use of a Lycox catheter. I'm going to talk about that later, okay? Big thing to remember is that we do not do lumbar punctures, no lumbar punctures. We don't do them because that would cause a release of pressure, and that could go ahead and trigger a cerebral herniation. Okay? The next slide just shows you where you can put some monitors. This slide is also out of your book. You've got multiple different methods, and this is just giving you a visual picture. Okay. Measuring and monitoring of ICP is used as a guide to clinical care whenever a patient is at risk or has an elevation in intracranial pressure. It can be used in patients with a variety of neurological insults such as hemorrhage, stroke, tumor, TBI. Anybody who's admitted with a Glasgow Coma Scale of 8 or less, and with an abnormal CT scan or abnormal MRI, should be closely monitored. we're going to monitor to begin the hopes of detecting an increase in the intracranial pressure before we have brain damage. We can use an intraventricular catheter. We can use a subarachnoid bolt, an epidural or subdural catheter, or fiber optics. I'm going to talk about them a little bit later on. The gold standard of measuring ICP is the ventriculostomy. And this is a specialized catheter. It's inserted into the lateral ventricle, and it's coupled to an external transducer which records pressure in the form of electrical impulses. One of the really good things about this is it also allows for drainage of CSF. And if there's blood in the ventricles, we can also drain blood from the ventricles. It allows us to continuously monitor pressure, and also gives us an option of doing either intermittent or continuous drainage. We can also give medications. It's more technical than the subarachnoid screws. One of the difficulties with it is that it can bleed spontaneously, and it can also get infected. Then we can also use a subarachnoid screw or bolt. This is another method, and it's placed through the skull between the arachnoid membrane and the cerebral cortex. Downsides, it does not allow for drainage of CSF, but it is a really good choice for patients with mild or moderate head injury. It can be easily converted into a ventriculostomy if the patient begins to decompensate. There's typically less brain complications from brain shift and ventricular size, but some complications are infection and blockage. Then we also could use a fiber optic catheter. This is an alternative method. It uses a sensor located in the catheter tip and is placed within the ventricle, or it can be placed in the brain tissue, and it gives us a direct measurement of brain pressure. One of the downsides of this is it's very expensive. Another downside is that tip can easily break. So that's not very good when that happens. This is just a picture of a ventriculostomy in place. Remember, we can drain. So you can see that it has a three-way stopcock on it. So when ICP exceeds the upper pressure that's set by the physician, sometimes we can use intermittent drainage, or we can use continuous. If we're doing intermittent, then we just basically want to turn that three-way stopcock to flow into the drainage bag. We don't want that to be very long. Only drain for about 30 to 120 seconds until the pressure is below the upper limit. Okay? Some things that we do have to do with the ventriculostomy is we have to level it. Okay, so it's important to keep that level with the foramen of Monroe, or the intraventricular foramen, and so a good reference point for this is the tragus of the ear. If we reposition the patient, remember that we also have to reposition the system as well. So that is something to remember with that method. This slide shows you measurement of ICP. Remember, we're going to monitor and prevent infection. We're measuring ICP as a mean pressure, and this shows you the waveform. The waveform diagram that's here is also in your book, and it's probably a little clearer because it's bigger to see that. Some things that we need to think about is the development of infection. Some things that contribute to the development of infection related to ICP monitoring is if we've got that monitoring going on for more than 5 days. Okay, we can also know that the use of a ventriculostomy increases the risk, and if we've got any kind of a CSF leak or any kind of concurrent systemic infection. So we want to have routine inspection of that insertion site. Always use strict aseptic technique. We're going to monitor that CFS for any change. Remember, going all the way back, we talked about what normal CFS should look like. So now we're looking for any change. So we have any drainage color. We're looking for clarity. Remember, it should be clear, it should be odorless, it should be colorless. If we do have a CFS drainage device in place and we want to measure ICP, remember that we have to turn that drain off. So if we've got continuous draining going on, we need to turn that stopcock back and turn that off. It needs to be closed for at least 6 minutes for us to get an accurate reading. If we don't do that, we're not going to get accurate readings of our intracranial pressure. Let's see. Whenever we look at those waveforms, an easy way to remember this is that a normal waveform should look like a staircase if we've got normal ICP going on. We need to continue to evaluate changes in the patient's condition, because remember that we can have changes occur very rapidly. Neurological deterioration might not occur until we see an increase that is pronounced and sustained. We need to immediately report to the healthcare provider any ICP elevation. And we might see that either as a change in the mean values that we've taken, or we might see that in a change in development of an abnormal waveform configuration. Some things that can impact an inaccurate reading of ICP are things like a CFS leak, obstruction, where we've not made the changes in the height of the system. Also, if there's bubbles or air in the tubing, because that can actually suppress the waveform. Managing measurement of ICP. With the ventricular catheter, it's possible to control the ICP by removing CFS. And the way this will typically happen is the physician's going to order a specific level to initiate drainage. So, for example, let's say that it's greater than 20 millimeters. That order would also list the frequency of the drainage and whether it's intermittent or continuous. When the ICP is above the indicated level, we can use that ventriculostomy system to open it up, that stopcock, allow the drainage, relieve the pressure inside the valve. There's two options, intermittent or continuous. If it's intermittent, you open the ventriculostomy system. At the indicated ICP, you let it drain for about 2 to 3 minutes, and you close it. Okay, if you've got a continuous drainage going on, you have to very carefully monitor the volume of CFS drain. Going back, remember back to that early collaborate I talked about, that CFS production is about 20 to 30 milliliters an hour, and our total volume is about 90 to 150 milliliters in the ventricles and the subarachnoid space. So we need to be paying attention to how much we're draining off. We also, another thing that's really a good thing to do is to have a sign posted at the patient's bed so that we don't do any turning or moving of that patient or any suctioning either to prevent the removal of too much CSF and some other complications. Always use strict aseptic techniques during any dressing changes or sampling of the CSF, okay? Some complications could be ventricular collapse, an infection or herniation. We could also get a subdural hematoma from rapid decompensation. Measurement of the cerebral oxygenation and perfusion. Remember, I talked about that Lycox catheter. It's a system that provides continuous monitoring of the pressure of oxygen in the brain, and that's abbreviated as PVT02. Our normal range is 20 to 40 millimeters. If we get lower than that, it's a sign of ischemia. Another advantage of the Lycox catheter is we can measure brain temperature, which is also very important. Remember, we talked about we can be able to prevent complications and we're going to have better outcomes. Another way that we can monitor oxygenation and perfusion is through a jugular venous valve catheter. Moving forward. As far as collaborative care is concerned, the goals include to identify and treat the underlying cause of the increased ICP, and we also want to support adequate brain function. The earlier the condition is recognized and treated, the better the outcome. That's why a careful history is a really good diagnostic aid, because it can give us some insight into the underlying cause. Remember, we need to keep adequate oxygenation, and I've given you some ranges there, okay? And if we have an increased ICP from a lesion, then the surgical removal of the mass is the best treatment. In aggressive situations, we might do a craniotomy in order to relieve ICP and prevent herniation. If they're having problems with adequate oxygenation, a natural progression would be to intubate that patient and put them on a mechanical ventilator to make sure they've got adequate oxygenation. From a drug therapy standpoint, that's the next slide we're going to talk about. Mannitol is really pretty much the major drug that we talk about for the most part. We also talk about corticosteroids, but mannitol plays a huge role in managing increased ICP. It's a diuretic. It's an osmotic diuretic. We give it IV. It acts to decrease the ICP through both plasma expansion and osmotic effect. There's an immediate plasma expanding effect that reduces the hematocrit and the blood viscosity. Thereby, it increases the cerebral blood flow, and as a result, the cerebral blood oxygen delivery. Let's see. We want to monitor fluid and electrolytes whenever we give the mannitol. We can also use hypertonic saline, and you guys have talked about that before. And the way that that works is it just produces a massive movement of water out of the swollen or the edematous brain cells and into the blood vessels. If we're going to do that, we need to keep very close monitoring of blood pressure and serum sodium levels. It has been shown that hypertonic saline can be just as effective as mannitol. And a lot of times we use them together whenever we're trying to deal with the situation. Moving on down, we're also going to talk about corticosteroids. We can use corticosteroids as well. The most common one you'll see is dexamethasone. The trade name for that is Decadron. We use it for vasogenic edema. Let's see. These are not recommended. We don't use it for head injury patients. When it stabilizes the cell membrane, it helps to prevent inflammatory mediators. Some complications include hyperglycemia, increased incidence of infections, and GI bleeding. We need to keep an eye on fluid intake, sodium and glucose levels. We should do blood glucoses at least every 6 hours. We also need to remember to give them also antacids or H2 receptor blockers, things like Tagamet. We could give them protein pump inhibitors, but one of our goals is to prevent GI ulcers and bleeding. Some other drugs that we can use anti-seizure medication. We can use antipyretics. The reason we'd want to use antipyretics, we would use that for an elevated fever because it's going to cause agitation, shivering. Same thing along the lines of seizures. Any of these things are going to just increase intracranial pressure. Our goal is to reduce metabolic demand for the body in order to lower the ICP in the at-risk patient. We do need to keep a close eye for seizure activity. They may need to be put on a prophylactic anti-seizure medication. Again, we already talked about controlling temperature, so we could use antipyretics. We can also use things like a cooling blanket, ice packs. We just want to keep that metabolic workload of the brain down. We can even use sedatives if we need to. We have to use analgesics to manage pain, but again, we don't want to over-medicate. We should keep them in a calm, quiet environment, minimal noise and interruption. Watch the patient for any signs of agitation, frustration, irritation, any of these things that we want to try to avoid. When we use drug therapy to reduce the cerebral metabolism, it can be a very effective strategy because by reducing the metabolic rate, we can decrease the cerebral blood flow and therefore the intracranial pressure. We sometimes use high doses of barbiturates with increased ICP that is non-responsive to other treatments. We use barbiturates. What we're actually doing is decreasing the cerebral metabolism. That's going to decrease our ICP. It's also going to decrease the cerebral edema. Then we're going to move on to nutrition. So when we're talking about ICP, they have to have their nutritional needs met, regardless of whether or not they're conscious. We see that if they fall into malnutrition, that's going to promote continued cerebral edema. So we want to recognize that that patient with ICP is in a hypermetabolic and hypercatabolic state that increases the needs of glucose. So we have to give them the adequate fuel. If they can't maintain an oral intake, we need to go ahead and move right into feedings. So often we'll start nutritional replacement feedings within 3 days of the injury to get the full nutritional replacement. They should be kept in a normal volemic state. So we're going to continuously evaluate the patients based on clinical factors such as urine output. We're also going to watch for insensible fluid losses. We're watching serum and urine osmolality, and we're paying attention to electrolytes. The preferred fluid is normal saline for administration of piggyback meds. And the reason for that is that if we use D5W or 0.45 half-strength sodium chloride, then we're going to have a decrease in the serum osmolality, and that's going to in turn increase the cerebral edema. Moving on to the next slide, we're going to talk about nursing assessment. So as far as subjective data is concerned, you need to get information from a reliable person. So if that person is not reliable, you need to use someone else, someone who's familiar with that patient. You want to describe level of consciousness by noting the specific behaviors that you observe. And reminder, changes in level of consciousness are the earliest and most consistent symptoms that you're going to see. You're going to need to learn the Glasgow Coma Scale. The Glasgow Coma Scale is in your book. It's on table 57-6. You need to know this because this is the skill that we have to test in Nursing 230. So I want you to look at that table. I want you to know how to do the Glasgow Coma Scale. And the way we'll test it is we'll have a couple situations that I'll put out for you, and you'll need to score that person on the Glasgow Coma Scale. Okay? The Glasgow Coma Scale is a very quick, practical, and standardized system. There's 3 indicators that we're evaluating. We're evaluating opening of the eyes, the best verbal response, and the best motor response. If you look at that table, it's going to tell you exactly what you're looking for. Okay? It's important to not only think about the overall score, but think about the subscale scores, because that's going to give you some more information about where perhaps the injury or insult is at. The total Glasgow Coma Scale is the sum of the numeric values assigned to each of the 3 areas. The highest Glasgow Coma Scale score that you can get is a 15, and that's for a fully alert, functioning individual. And the lowest possible score you can get is a 3. A Glasgow Coma Scale of less than or equal to 8 is generally indicative of coma. You can plot it on a graph if you want to see how it goes, okay? As far as nursing assessment, cranial nerves. Remember I told you you'd have to have cranial nerves in order to recognize them from a pathological standpoint. You're going to compare the pupils one another for size, shape, movement, and reactivity. If you've got a compression of cranial nerve 3, which is the oculomotor nerve, the pupil on the affected side is going to be larger until it fully dilates. If the ICP continues to increase, eventually you're going to see both pupils dilate. A fixed pupil unresponsive to light stimulus usually indicates increased ICP. Remember, however, when you're looking at that history, there are some other causes that could result in that fixed pupil. It could be a direct injury to the cranial nerve 3. It could be some previous eye surgery. It could also be because atropine's been administered, or they might have just gotten some mydriatic eye drops. As far as evaluation of other cranial nerves, remember we talked about eye movements are controlled by cranial nerves 3, 4, and 6. And you can assess this in the patient who is awake by having them follow commands. You can test the corneal reflex, which gives information about functioning of cranial nerves 5 and 7. If that reflex is absent, then we need to initiate routine eye care to prevent corneal abrasion. If that patient's uncooperative or unconscious, we can still evaluate eye movement by eliciting a reflex with the use of head movements, the oculocephalic, and the caloric stimulation, which is the oculovestibular. The one that we use more often is the oculocephalic. And to test this, which is also called Dahl's reflex, you just turn the patient's head briskly or quickly from left to right, okay, while holding the eyelids open. In a normal response, the eyes are going to cross the midline in the direction opposite that they're turning, okay? Then quickly you can flex and extend the neck. And again, the movement should be opposite of the head movement. So if you duck the head down quickly, the eyes should normally go up, okay? But instead, the reason it's called doll's eyes is if you've ever seen a doll where the eyes are just fixed, you turn the head, the doll's eyes go right with it. You put the head down, the doll's eyes go right with it. So there's no reaction. So that would be an abnormal response would help to locate an intracranial lesion. Caution, since we're talking about brain injury. You would not do this if there was any suspicion at all that you had a cervical spinal problem. Okay, don't do this then. This is again that same chart showing you the pupillary reactions. We're going to move on. We're continuing to assess. Now we're looking for motor strength and motor response. Motor strength is they're alert and oriented. You can have them squeeze your hands. You also can check them for palmar drift test. This is a good measure of upper extremity strength. And in this, you basically have that patient raise their arms in front of their body with their palms down. Put it backwards. Put their arms in front of them with their palms up. Put it totally backwards. If there's any weakness, you're going to start to see that palmar surface to turn down and the arm is going to drift down. You can also ask the patient to raise their foot or to bend from the bed or bend their knees. This is a good assessment of lower extremity strength. You want to test all 4 extremities to look for if there's any problems with asymmetry in strength or movement. If you've got an unconscious or an uncooperative patient, you can test them by spontaneous movement. There should be some natural resistance during passive range of motion is another way to check strength. If you've got an unconscious patient, then don't include the hand squeezing part of the assessment of the motor movement because in the unconscious or uncooperative patient, this is like a reflex action and it's going to give you a false reading. Remember also to pay attention to the vital signs. Again, remember Cushing's triad. Besides recording respiratory rate, you also want to look at respiratory pattern. And the next slide is going to show you some different patterns. Okay, and this is just in here. You can read this slide. It shows you different patterns of respiratory patterns associated with coma. Respiratory function, of course, we want to maintain a patent airway. This is critical with the patient with increased intracranial pressure, and it's a primary nursing responsibility. As level of consciousness decreases, the patient's risk of impaired airway obstruction increases from the tongue dropping back and occluding the airway, and also from the accumulation of secretion. In general, if you've got a Glasgow Coma scale of 8 or lower, or an altered level of consciousness, who's unable to maintain the patient airway or effective ventilation, we're going to go with intubation and mechanical ventilation. We want to prevent hypoxia and hypercapnia in order to minimize secondary injury. A proper positioning is an elevation of the bed at 30 degrees to enhance respiratory exchange and also to decrease cerebral edema. We want to remove accumulated secretions by suctioning as needed. An oral airway helps to facilitate breathing. Something that we need to think about in suctioning, though, and this is important, you need to remember this, is that when we suction and we cough, we're also causing a temporary decrease in our oxygenation, and that's going to result in an increase in ICP. So So if we've already got a patient with increased ICP, when we suction them, we're even making it even worse, okay? So if you are going to suction, you want to keep it at a minimum, do less than 10 seconds in duration. Some places say no more than 2 passes. And you want to do this with the administration of 100% oxygen before and after to do everything we can to cut down on that decrease in our oxygenation. Let's see, we want to prevent abdominal distension, so we might put an NG tube in. But again, there's something to remember here, that we would not do that if that patient has a basilar skull fracture. We need to watch the ABGs. We're paying attention to both the oxygen and the carbon dioxide levels. We want to continue to work to minimize increases in ICP. Some things we want to remember is that simple things like the Valsalva movement, coughing, sneezing, suctioning, arousal from sleep, any of these things can increase ICP. So we want to be alert to these factors and minimize things that can increase ICP. We want to prevent any type of extreme neck flexion because this can cause venous obstruction and continue to push the ICP up. We want to keep the head of bed appropriately elevated. Again, that's about 30 degrees. Okay, that's going to help to decrease the CPP by lowering the systemic BP. Position the bed so that it lowers the ICP while optimizing the CPP. We always want to turn them with slow, gentle movements because any rapid movement can also increase intracranial pressure. We want to prevent discomfort, and that's again because pain and agitation increases intracranial pressure. An increased intrathoracic pressure is going to increase ICP, so that can happen with coughing, straining, and the Valsalva movement. Any type of extreme hip flexion can possibly cause an increase in intra-abdominal pressure, which in turn increases ICP. A lot to remember and think of. Pain management, we can manage their pain through the use of opioids, such as morphine sulfate, any type of a rapid-acting analgesic. We can also give them propofol. It's gotten more and more popular to manage anxiety and agitation. The main reason it's gotten popular is it has a quick onset and it has a very short half-life. We can give them continuous IV sedation with dethylmethyltrimide. We can use neuromuscular blocking agents. That's we would use those, and that would be something like Vecurium, VECURONIUM. And then we do that whenever we want to just totally control ventilation so that we prevent any refractory intracranial hypertension. What they do is they paralyze the muscles, but it's important to remember that even though it paralyzes the muscles, it doesn't block pain. So we usually also give them sedative analgesics or benzos. We can use benzodiazepines for sedation, although typically we try to avoid this if possible because it causes hypotension and also a long half-life. So like I said, but we do use them in conjunction with the neuromuscular blocking agents. We're getting close to the end, I promise. Fluid and electrolyte balance, we want to monitor for accurate intake and output. We want to watch electrolytes. Remember we talked about the syndrome of inappropriate antidiuretic hormone. We talked about that. We talked about diabetes insipidus. So we want to keep a close eye on both of these as crossover is happening. So we're paying attention there. We're going to pay attention also to immobility, and this is the last slide. So we're trying to protect them also from self-injury. Some things from immobility that we're trying to prevent are things like atelectasis and contractures. Even though we want to protect them from self-injury, we want to be very careful about the use of restraints. Remember, we can use sedatives, but we also want to think about the impact on level of consciousness. For the patient with seizures, if the person is likely to develop seizures, we're going to institute seizure precautions. If we're going to have seizures in this patient, most likely in the first 7 days following a traumatic injury, so sometimes we do prophylactic anti-seizure therapy. Again, keep them in a quiet, non-stimulating environment. Always use a very calm, slow, reassuring approach when you're caring for the patient. You do want to remember to always touch and talk to that patient, even a patient that is in a coma. Just be aware of the psychological considerations, not only for them, but for their family. And you might have to have a very broad interdisciplinary focus. And that does wrap this up. So I'm going to wrap it up.